Hello, my name is Dr. Brian Solomon. I'm a heart and lung surgeon in the Department of Cardiothoracic Surgery at the Naples Community Hospital Heart Institute. I'm also part of the structural heart team. Today I am here to discuss transcatheter aortic valve replacement. This is a technology which is transforming the treatment of aortic valve disease. So we'll begin by talking about aortic stenosis. What is aortic stenosis? Well, aortic stenosis is the buildup of calcium deposits on the aortic valve, which causes it to narrow and reduce blood flow to the rest of the body. You'll see from these pictures we have an image of healthy and diseased aortic valves. As calcium builds up on the aortic valve over time, the valves become tighter and immobile, and as a result, it requires extra pressure generated by the heart to force blood into the aorta and to the body. This creates stress on the heart, which can lead to heart failure if it's not treated. The symptoms of aortic stenosis can include several of the very common symptoms from coronary disease and from what's generally considered aging. These include shortness of breath, fatigue, difficulty walking short distances, lightheadedness, dizziness, swollen ankles and feet, rapid fluttering heartbeat, chest pain, and no longer taking part of physical activities. Because these can be symptoms of heart failure or aortic stenosis or other valvular disease or coronary disease, it's important that a clinical expert see the patient and determine the exact cause of the symptoms and whether or not treatment is necessary. The risk factors for aortic stenosis and causes include calcium buildup, congenital birth defect, rheumatic fever, and radiation therapy. Rheumatic fever and radiation therapy have been decreasing in the United States over the past 50 years due to better diagnostic and therapeutic treatment of these diseases. Degenerative calcium buildup or degenerative valve disease is the cause of the vast majority of severe aortic stenosis. The risk factors include increasing age, high blood pressure, abnormal cholesterol level, smoking, deformed aortic valve, and family history. As you see here, we have images of calcific aortic valve stenosis on the bottom right, a normal aortic valve on the top left, a bicuspid valve on the top right, and a rheumatic valve on the bottom left. This just shows that the most common is calcific aortic stenosis in patients generally over the age of 65, where the edges of the valve tighten because of calcium deposits and leave the valve unable to move. The population at risk for aortic stenosis is increasing. We have about 2.5 million people in the United States over the age of 75 suffering with aortic stenosis. That's about 12.4% of the population over the age of 75. The elderly population is increasing, especially in Naples. And between now and the year 2050, we expect the elderly population in the United States to double. This leaves more patients at risk for aortic stenosis, making it a priority for us to diagnose and treat this. At least 40% of patients who have severe symptomatic aortic stenosis do not actually get the treatment they need for their disease. This has been proven through 7 national studies over the last 7 years. The studies show that with severe aortic stenosis, patients are generally underdiagnosed, undertreated, and can do much better if they are found early. These graphs are critical. The one on the right shows the 3 symptoms and the symptom progression for aortic stenosis. Angina, syncope, and heart failure is the triad of aortic stenosis, and that's the paradigm for how symptoms will present. Patients generally present with chest pain or angina, can develop syncope or passing out and dizziness, and then can lead to heart failure with shortness of breath. What we see from the graph on the left is that aortic stenosis has a long latent period. Patients can go for 60, 70, or 80 years without ever knowing they have symptoms. But as soon as they have symptoms, their survival rate rapidly declines. Survival after the onset of symptoms is 50% at 2 years. Survival is 20% at 5 years. Surgical intervention should be performed once symptoms, even minor ones, occur. The important thing is noting that once this treatment is performed, the patient's lifespan goes back to almost normal. And instead of having a 2-year survival, patients can live a normal length life. For comparison, I'd like to compare severe inoperable aortic stenosis to 5 of the more common cancers that we see in the United States. These are generally known as some of the bad cancers, ones that are prevalent and ones that can have poor survival. This includes breast cancer, lung cancer, colorectal cancer, prostate cancer, and ovarian cancer. There's a lot of attention nationally to these disease processes because they're things that we want to know about, they're things we want to screen for, and they're things that we want to treat. What we don't realize is that the 5-year survival for somebody with severe inoperable aortic stenosis is lower than any of these conditions. It's only 3%. But once treated, unlike some of the other conditions, we're able to nearly guarantee the patient can live a full lifespan without complication and without need to replace the valve. So we've established that aortic stenosis is a prevalent problem and what it is, but how do we diagnose it? Well, tried and true, the first thing is symptoms. We need to talk to an expert, whether that's your primary doctor or your cardiologist or your surgeon. You need to talk to an expert and present your symptoms. From there, the expert will determine what tests need to be done. The most common will be an echocardiogram. This allows us to present 2D and 3D images and to determine the velocities of the fluid going across each of the valves. We're able to measure the velocity at the aortic valve, the valve area, and the gradients. We look for a velocity greater than 4 meters per second across the valve. We look for a valve area less than 1 square centimeter, or a mean gradient greater than 40 millimeters of mercury. There are also minor factors that we look for, including progressive disease, a decrease in the valve area of greater than 0.5 centimeters squared per year, and aortic insufficiency. And all of these factors together will allow us to determine whether the valve is ready to be fixed and whether it's the cause of the symptoms. As I mentioned, there are diagnostic guidelines. We look for a velocity greater than 4 meters per second, a mean gradient greater than 40, a valve area less than 1. This is a busy slide, but it just goes through the recommendations when somebody presents with this data for when they should actually be replaced. The aortic valve replacement should be performed in severe patients with symptoms. That's the class 1 indication, or we like to call any patient with these symptoms and severe aortic stenosis needs a replacement. There are other indications for aortic valve replacement. That includes reduced ejection fraction, the need for other cardiac surgeries, or rapidly progressive disease. This is another busy slide, but it just goes to show the decision tree and that it's a very complicated system to determine whether or not somebody is actually a candidate for surgery once they have aortic stenosis. And these are all the factors that go into the decision tree. There are some special considerations. The most common is low flow, low gradient aortic stenosis. This is a unique version of aortic stenosis. You see, we look at gradients and we look at velocities across the valve, but that makes the assumption the heart is strong enough to squeeze the blood hard enough to create these velocities and gradients. If we get to the patient somewhat late and the aortic stenosis has led to heart failure, the heart may not be able to physically squeeze hard enough to generate these velocities and gradients. That doesn't mean the aortic stenosis is better. It just means the heart is so weak that it's not able to get to this point. So we're able to look at the valve area, but we're also able to perform other tests to determine whether or not the patient is a candidate for aortic valve replacement. In the setting of this low flow, low gradient aortic stenosis, we can perform a test called the dobutamine stress test, where a chemical is given to the heart called dobutamine to force it to squeeze harder and try to generate the gradient and velocity on echocardiogram. If the patient's not a candidate for this, we can also do a specific CT calcium score, which can allow us to directly measure the amount of calcium on the aortic leaflets. Up to 35% of patients with severe aortic stenosis can present with low flow, low gradient aortic stenosis. And it is a treatable disease, which we can bring the patient back from, and they can recover function of their heart if treated timely and appropriately. So once they're diagnosed, how do we treat aortic stenosis? Well, the tried and true method has always been the surgical aortic valve replacement. It's been around for over 50 years. It requires a 10-inch incision in the chest. We open the chest, we expose the heart and put the patient on cardiopulmonary bypass. We remove the current valve, which is diseased, and we put a new valve in. That valve can be a tissue valve or a mechanical valve. There are benefits and risks to each. A tissue valve has an expected lifespan of 15 to 25 years. This has been improved over the last 10 to 15 years with new techniques in building the valves, but 25 years is generally the higher length of lifespan which is given for these valves. The benefits to these valves is that the patient does not need to take any anticoagulation, and if anything does go wrong with the valve, a transcatheter valve can be placed in the future within it. Mechanical valves, on the other hand, have an unlimited lifespan theoretically. There are patients that have these valves that have lived with them for over 50 years. Patients do very well with them, but they do require the patient to be on anticoagulation. Generally, this is Coumadin. There are some patients which cannot tolerate Coumadin or don't want to tolerate Coumadin, and this is a factor that goes into the decision tree for which type of valve is chosen. Another important factor is if anything does go wrong with this valve over time, a transcatheter valve cannot be placed within it. Over the last 15 to 20 years, minimally invasive aortic valve replacement has become a standard of care. Instead of the 10 to 12 inch incision in the chest, we make a 2 to 3 inch incision in the upper chest. The majority of the bone stays intact. The patient has the same surgery, the same valve options, and the same valve longevity as open surgery, but it's done through a smaller incision. Otherwise, it's exactly the same operation. It has a shorter length of stay, it has less pain, but it does require the surgeon to have a minimally invasive skill set and averages only 3 days in the hospital. This has been the majority of our aortic valve replacements at Naples Community Hospital. For isolated aortic valve replacements, I'd say greater than 95% of patients undergo the minimally invasive approach. We don't make the full sternotomy or the traditional sternotomy unless the patient needs another procedure done at the same time, including an aortic replacement or a bypass or another valve to be done. Generally, most surgeries can be done this way. And approximately 8 years ago, transcatheter aortic valve replacement came on scene in the United States. It's generally performed through the femoral artery through a transcutaneous access, meaning we stick a needle into the artery in the groin, we dilate that to a larger catheter, and we're able to put the valve through the groin up around the aortic valve, up around the aorta and into the aortic valve. The benefits are the heart doesn't need to be stopped, we don't need cardiopulmonary bypass, and the patient's able to go home in 1 to 2 days with less pain. This is a picture of the procedure being done, and it shows that it requires several doctors coming together in a single procedure in the cath lab to get the procedure done. It really is a meeting of the minds for this. We determine the appropriateness for each patient for the valve, the sizing of the valve in advance, and as I tell the patient, 90% of the procedure is done before they're even in the room. What we see here from these graphs is that regardless of symptoms, patients who have their aortic valve replaced for severe aortic stenosis have a dramatically increased survival and do well. The procedure for transcatheter aortic valve replacement is performed by the structural heart team. This includes a cardiac surgeon, an interventional cardiologist, a cardiac anesthesiologist, a non-invasive cardiologist, a cardiac surgical team, an interventional cardiology team, and a cardiac perfusion team. It seems busy and it does get crowded in the room, but this is the way we come together to provide a safe environment for the patient by bringing all the experts in at once. This really has been a paradigm change in cardiology care. You see, about 10 years ago, before TAVR was standard, when you came to a doctor, you were treated by just that doctor and his knowledge base. And if he didn't know how to treat you, you were sent to another doctor. In this case, you're seen by a team of doctors, you're evaluated by several people independently who then come together and decide how they are going to work together to treat the patient best. And that's really been a paradigm shift for all of cardiology, allowing us to work together as a single team and get better outcomes for our patients. So the workup is complex. First, you're referred to the structural heart team. You're seen by 2 surgeons and 1 interventional cardiologist independently, who then come together and go through the data and do measurements and determine whether you're a candidate for this procedure. The key to this is we want to present the right option for the patient. So we want to determine, will this patient do better with surgical replacement or transcatheter replacement of their valve? And this is where the meeting of the minds happens and we come together and determine what's right for the patient. We're going to get a CAT scan of the patient from the upper chest all the way down to the groins and perform a 3D reconstruction of all the vasculature and look for any other comorbidities and make sure the vasculature is appropriate for a valve. We're going to size the valve and determine the size for the delivery system and make sure the arteries are big enough and the aortic annulus is big enough to place the appropriate size valve for the patient. We're going to look at the carotid arteries, the vessels in the legs, and do a breathing test. We're going to do an echocardiogram. We're going to do a cardiac cath. We're going to do lab work, and we're going to measure a frailty score, including a 6-minute walk test and a heart failure questionnaire. All of this comes together to determine candidacy for the valve. The majority of these procedures are performed electively. Greater than 90% are performed in patients that come in as an outpatient for evaluation and are done safely and electively without any emergent situation. The hospital process is straightforward. You're admitted on the day of the procedure. You come to the cath lab, and the procedure takes 1 to 2 hours. That's a little bit of an exaggeration. I will say the procedure itself takes about 45 minutes. The 1 to 2 hours includes the time for anesthesia and the time for waking up the patient. The majority of patients have the breathing tube taken out in the cath lab, and now a good number of these patients are being done under sedation rather than being intubated and having general anesthesia. The patients are admitted to the TAVR team and go to the ICU for postoperative care. They spend 1 night there and then go to a regular room. Most patients are walking within 6 hours, and I'd say our average length of stay is 1 to 3 days, depending on the patient's medical status, but most patients go home in about 36 hours after the procedure. This shows our 2 most commonly used valves at NCH. The Edwards Sapien valve really is the bulk of what we do. There are other valves in the market, but Edwards Sapien really has become the most commonly used valve nationally, and I believe the standard of care. It's got a stainless steel frame. It's a tissue valve. It's listed as having more aortic regurgitation than the other valve, but really this is less than 1%. And it has dramatically improved over the last 10 years to the point that we almost never see aortic regurgitation now. It has a decreased need for a pacemaker or causing any kind of heart rhythm blockage, and it's a balloon expandable device. That means it's a very small device that goes through the groin, and a balloon goes within it, and the balloon expands the size of the valve, which we'll see later. The other valve, the Medtronic core valve, is a nitinol expanding frame. It's a self-expanding frame. So it goes in on a stent, and the stent self-expands to the appropriate size for the aorta. It intentionally oversizes in the aorta, pushing on the wall in order to decrease leak around the valve. But this can lead to more pacemaker need and more heart block. So generally, we find the Edwards Sapien valve is appropriate for more of our patients, and it tends to be our go-to valve. This slide just shows the complex workup done for each patient. You'll see all the imaging that comes together and all the measurements that are done to determine exactly what size valve can be placed in the patient to do the procedure safely and appropriately. This is what I mean by 90% of the work is done before the patient's ever in the room. It's all the mapping and the 3D reconstructions that allow us to know exactly where to place the valve so that in 45 minutes we can be in and out without having any discussion about sizing in the operating room. Everything is done beforehand so that it's done safely. This is just showing a brief video of the valve implantation in a patient. It was provided to me by Edwards, which is the manufacturer of our most common valve, and it shows the Sapien 3 valve going into the aorta through the commander system, which is the name of our sheath. You'll see here the sheath is already in place, and we have a wire in the heart, and we're going to go up through the aorta. We're going to come around the aortic arch, and we're going to go through the aortic valve here in order to break the valve open with this balloon. We pace the heart, and we break the valve open so that there's no embolization, and we minimize the risk of a stroke. We leave the wire in place, and we pull the balloon out. And next, through the same wire, we're going to insert the valve. The valve goes on the delivery system, but it would be too large to put through the groin, so we need to build the valve within the patient. So here you're seeing the valve is in place, and we're going to pull the balloon into the valve so that it can be deployed in the patient. Now it's going to be fine-tuned, and as I mentioned, the patient's going to require rapid pacing. We can't expand the valve with the heart beating because we risk the valve flying off into the aorta. So we're going to temporarily stop the heart using a pacemaker and rapidly pacing the heart. Here we're coming around the aortic arch, and we're using a steering mechanism to avoid hitting the walls. And we come over the wire, and we're going to go past the coronaries through the aortic valve. And now we're going to pull the sheath back, and we're going to fine-tune exactly where the valve sits. And we're looking at the markers, we're comparing it to the CAT scan, and we're centering the valve so that it's in the right position. As I said, we're going to fine-tune exactly where it's going to sit to minimize the need for a pacemaker or complication. We're going to pace the heart rapidly to prevent it from beating and expand the valve with the balloon. This wedges the valve in place, and once the balloon is deflated, we remove the entire system, and the patient has a new working aortic valve. So the outcomes have been excellent with this. As I mentioned, this started in about 2012, and initially it required a much bigger incision, a cut down on the groin, and had a much higher mortality of about 6.5%. Over the course of the last 8 years, we've developed 3 generations of valves. We're now just debuting the 4th generation of the valve, and the mortality of this procedure is down to about 1.1%, which is excellent and on level with surgical aortic valve replacement. So as I said, 2012 is when these came out, and the PARTNER 1 trial was the first trial that looked into it. It was the original trial in the US to look at severe aortic stenosis treatment by TAVR. It was a multi-center trial across the United States. It was randomized, and the patients were all considered high risk, meaning they had at least a 10% chance of mortality from the operation. Some of them were even considered inoperable risk, meaning greater than 15% mortality from an operation. As a result, they were randomized to either medical treatment or undergoing a transcatheter aortic valve replacement. And then they were broken down and compared to surgical treatment. This just shows the study design and showing that it included almost 1,100 patients in a parallel study. It also looked at transapical and transfemoral valve placement. We don't need to talk about transapical because it's really not done very much anymore. Almost everything is done through the femoral arteries percutaneously. The endpoints looked at death and rate of severe complication. They looked at rates of heart failure and risk of performance changes. And the results basically showed that for the very high risk patients, aortic valve replacement via surgery or transcatheter valve had the same outcomes. Patients had a slightly higher risk of stroke, but in general, their survival was excellent. The conclusions were, in patients not suitable for surgery, transcatheter aortic valve replacement had reduced rate of death from any cause compared to medical management, and that patients had an equal outcome whether they went through surgery or transcatheter valve for long-term mortality. About 4 to 5 years later, we moved to intermediate risk. These were patients that had between a 4 and 8% risk of mortality from surgical aortic valve replacement. And a very similar study was performed looking at transcatheter aortic valve replacement versus surgical aortic valve replacement. And the long-term results of PARTNER 2 showed that it was an equivocal result, meaning patients did just as well with a transcatheter aortic valve replacement or a surgical aortic valve replacement. Low-risk aortic patients was PARTNER 3. These are patients with a less than 4% risk of mortality from surgery. We compared surgery versus transcatheter aortic valve replacement and looked at data for 1 month and 1 year after the surgery. As you'll see here, the study did exclude a lot of patients. It excluded anybody with really low heart function or valvular abnormality or aortic insufficiency, and several other issues. But in general, it was a very good study and very comprehensive for low-risk patients. And the results showed that in the appropriately selected patients, low-risk patients with aortic stenosis actually did better for transcatheter aortic valve replacement compared to surgical aortic valve replacement. Though they did have an increased need for a pacemaker, increased risk of thrombosis of the valve within the first year after the surgery, and increased risk of leak around the valve. The most important pitfall in my mind was that while we came out and said low-risk patients are a candidate for transcatheter aortic valve replacement, I think we're realizing that we only had 1 to 2 year data on these patients. That's great for patients that are higher in operable risk, that are 90, 95 years old. But for patients that are low risk, these are generally patients in their 60s and maybe early 70s. These are patients that potentially have 25 years left to live. And we really need to know what the 25-year data is. The most common question that I get from patients is, how long is this valve going to last me? What's the downside of a transcatheter valve? And the problem is we just don't know. The valves have only been around for about 8 years in this country. We've only been placing them in low-risk patients for 1 year. So we really can't say how long the valves will last for. Our best guess is somewhere between 5 and 8 years, but the data isn't there to support that yet. We just don't know. So that's why it's critical that a patient be assessed by experts and we determine, are they a candidate for a transcatheter valve or are they a better candidate for a surgical valve? And that's where the structural heart team comes in. I just want to briefly touch on NCH's data and show how we're doing with transcatheter valve replacement. This just shows overall that our patients who undergo the procedure have a significant reduction in their heart failure symptoms after the procedure and feel much better. Symptoms are generally significantly reduced. This shows that the heart function stays exactly the same. The ejection fraction goes from 57% pre-TAVR to 57% average post-TAVR, meaning there's no deleterious effects that happen to the muscle of the heart from inserting this valve. This just shows the change in pressure gradients. As I told you, the pressure gradients and velocities are the ways that we measure the stress on the heart from aortic stenosis. And here the mean gradients are reduced from 41 down to 12, and the peak gradients are reduced from 72 to 24, showing dramatic improvement after insertion of the valve. And peak velocities have been reduced from approximately 4.3 down to approximately 2.4, which has been really significant for the patients. The future directions of our structural heart program, currently we started with just transcatheter aortic valve replacement. We've now moved on to do them for bicuspid aortic valves, for valve-in-valve procedures, meaning patients that have already had a surgical valve or a transcatheter valve can now get a second valve within them. We've now started placing mitral valve replacements within surgical valves. We are now doing closures of holes in the heart, including patent foramen ovale and atrial septal defects. We're placing transcatheter aortic valves in the mitral position where people have a calcified valve. We're doing Watchman procedures for atrial fibrillation, and we're doing low-risk transcatheter aortic valve replacements. I'm hoping in the next few years we'll also begin transcatheter mitral valve replacements when it's approved by the FDA. In conclusion, intermediate risk patients have resulted in low 1 year all-cause mortality, all-cause stroke, and residual aortic regurgitation, meaning this is a safe procedure doing transcatheter valve in intermediate risk patients. And since then, we've updated to include low risk patients. People do well with a transcatheter aortic valve replacement is generally what we're seeing. They do have a slightly increased risk of aortic insufficiency or leak around the valve and a slightly increased risk of need for a pacemaker. But in general, patients do well. But the takeaway point is it's an excellent alternative to traditional aortic valve surgery if the correct patient is chosen. Aortic valve surgery is an excellent option for patients if the correct patient is chosen. It's all about going to the expert and finding out what your long-term goals of care are and what is the best valve for you in order to fix the problem. It's indicated in high-risk patients, it's indicated in moderate-risk patients, and as of late, it is now indicated in low-risk patients. So anybody with severe symptoms from aortic stenosis really should come to be evaluated and determine if it's right for you. There is a slightly increased risk of paravalvular leak, of vascular injury, and pacemaker need. But as I mentioned, the big drawback is that it lacks long-term data. So we just really don't know how these valves are going to behave over the long term and what's right for the younger patients who may have 20 or 25 years left to live. And just further talk about how the data that we have really only goes out to about 5 to 8 years, and it just isn't enough data to assess durability of these valves. We're expecting 5 to 8 years of durability in the elderly. possibly less in younger patients, but we just don't know, and we're hoping that data will arrive over the next 10 years. But for now, it remains an excellent alternative for aortic valve surgery. If you have any questions, please feel free to contact me. You can call at this number at the Naples Heart Institute at NCH, and I'm happy to answer any questions or to see any patients in the office. Thank you very much for your time, and I look forward to any questions you may call about.